And today it's our pleasure to have Professor Dr. Manmohan Mehndiratta, who is presently working as Director of Janakpuri Super Speciality Hospital as an HOD as well as Director also. And so, Samarth, can you mute everyone, please? Yeah.
Vineet, you are muted. Vineet, you are muted.
Vineet, you are muted.
Yeah. Am I audible?
Too much of
Yes.
muting. Too much of muting. Yeah.
Yeah. Sorry. So good afternoon, everyone. On behalf of DOA, I welcome all of the delegates as well as panelists for the 16th session of the DOA PG class on the role of EMG NCV in the orthopedics. We are dealing daily, day-to-day practice. We are getting NCVs and EMG for our patients, but many of us are still yet to know how to read it properly, how to interpret it properly. And I think it will be a great learning for the PGs as well as for the faculty too. We are having the pleasure of company of Professor Dr. Manmohan Mehndiratta, who is presently working as Director of Janakpur Super Speciality Hospital, as well as HOD of Neurology Department. He is an internationally acclaimed faculty in the neurology, and he has more than 250 publications in his name in various high impact national and international journals. And he has more than 60 books chapter in his publication clout. And he is presently working in editor and for many journals of neurology, neurologist, and as well as psychiatry. And he has been honored by the Lifetime Achievement Award from the Coimbatore Neurology Society in 2017. And he has honorary membership of Japanese as well as Sri Lankan Neurological Society. And he is presently being awarded by the Ambassador of Epilepsy in the International League of Epilepsy. And presently, he has been conquered with the Delhi State Award in 2003 for his contribution in the field of health and family welfare. Now, without wasting much time, I would request Dr. Mehndiratta to start sharing his screen and deliver his presentation. Thank you very much.
I'll just take a minute and very good afternoon to all the friends, and my special thanks to Dr. Vineet Arora for asking me to come today on this topic and speak on NCV and EMG. That's the basic NCV and EMG. Can you see my slide or no?
Sir,
I'll stop sharing and then again start sharing. Yeah.
No, we could see, sir. We can repeat.
Okay, wonderful. So my grateful thanks to the moderators, Dr. Vineet Kumar Arora and Dr. Rehan ul Haq. And similarly, Dr. Sharad Agarwal, DOA President, and Dr. Hitesh Lal. You all are luminary in your field, but I had the first time opportunity to come across through virtual meeting, and I pay my regards to you. And I hope we'll be in a position to carry on such activities in the future for the benefit of our residents. So today's topic, what I like to share with you is primarily on NCV and EMG. We get many requests from different fields to get an EMG and NCV without getting the details about the patient or without knowing the significance of that. So I made it very, very simple, as Vineet rightly said, that first time we are having a non-neurologist in the orthopedics meeting. I hope that will be acceptable to all. And now I'll start sharing my screen. I have given it a little different title. You must be seeing that. That is Basics of NCV and EMG for my orthopedic colleagues and residents. I hope it is clearly visible, Vinitji.
Yes, sir.
And also grateful to Smarth for coordinating all this. Hosting is an art, and I keep on hosting number of meetings, but how to have it a smooth without hassles is an art. I always declare that my total slides are 57. There are cartoons and videos. Duration of talk shall be 37 to 38 minutes so that we can take up questions. I'll be using through the system audio and video till I have finished with my videos. Then I'll go to my earpod so that, because otherwise video becomes little difficult. Since many of you may not know, I like to tell something about my institute in brief, not too long. It is basically through some of the running videos, which I hope you people will like. You can see the here display board. When I joined, I said we must have a display board to tell the public what are we going to do today. Like if today it was in my institute, there would have been a message, Basics of NCV and EMG, organized by Delhi Orthopaedic Association. And then there are some international delegates also, because I have sent this link from African countries, they may be attending, and also greetings from New Delhi, India. While giving this talk, I have no conflict of interest. Now you can see this video. This is EMG, slightly painful. Listen to this voice, sound. Now you see high voltage discharges. And now you can see it's like as if there is a dive bomber. Many of you must have seen the Air Force plane on 26 January fly mast. I think I'll stop this and then show you later. Fly mast on the India Gate. Many of the residents who have joined must be having a feeling, it looks like my bike's sound. It is actually motorbike sound or dive bomber. Like the bomber comes and dives, it's that sound. So this EMG is fairly suggestive of a diagnosis called myotonia, which many of you may not know what is myotonia, but I'll touch upon that later. Now you will see further better thing. These are the muscle potentials. And in between you will see something different, and listen carefully. Look at this. This is another dive bomber which you must have heard.
Can't listen anything, Dr. Manmohan.
I don't know. I'm running on the system, but this is through the system anyhow.
Okay.
Why it's not audible? I have put it on. I'll check the video again. Audio. Because this audio is through the system, that's why I'm not using the let me see, audio, same as system. Maybe it's the volume is low. That may be the reason, sir. But soon I think I'll let us see whether we can listen to the other. There are two more videos. If not, then I'll explain. So this was a dive bomber, which is very commonly seen in myotonia EMG. Now you can see this is a discharge summary from my institute, which we always give all printed with clear-cut diagnosis written: chronic inflammatory demyelinating polyneuropathy, follow-up case of ankylosing spondylitis, two autoimmune conditions. I hope this video plays. Is it audible, sir? Is it audible now?
Sure. Yes, I think if you
Yeah.
can increase the volume, right?
This is my resident, Dr. Yogesh Sharma, who is taking the history from the patient. What is important here? Maintaining high professional ethics and taking a consent. You cannot record a video or send the photo of anyone without permission. So that is one professional ethics which all our residents and others should follow. I'll continue.
Audio is not still audible. Maybe you can narrate.
Okay, he's saying that he has got weakness in the limbs and also he has paresthesias. And he was diagnosed as CIDP, chronic inflammatory demyelinating neuropathy, and he is on maintenance dose of intravenous immunoglobulins. In this, diagnosis cannot be made without nerve conduction studies. So I'll go to next. I'm sorry why this is not playing. This is my institute, Janakpuri Super Speciality Hospital Society. I always say our workforce. All those who are standing here, I can narrate by name one and all, but you will see here, you will not see me in the first row, not in the second row, third row. I am somewhere here. So this is the front force which take care of all the activities of the institute, and it is a teamwork which matters. I'll show a few slides about the institute because many of you may not know, so that you know more, and later on, if DOA wants that the residents, orthopedic residents should have a training in this field for 2 weeks or 4 weeks, we'll be happy to extend. And there are technicians here. I'll show the next workforce. Now, plan of talk shall be brief introduction about our institution, definition of NCV and EMG, indications, consent, preparation and performing, interpretation, and carry home message. So one should be clear in indication. Not that just get median nerve done or ulnar nerve done, tardy ulnar nerve injury, or humerus middle part fracture and get radial nerve testing done. We should also know why we are getting it, what will be the benefit of it. And consent of the patient has to be taken. There has to be a preparation and performance, interpretation, and then carry home messages. Quickly, I pass through this. About the institution, I always believed in digitization. Our all reports are paperless. Most of the reports are printed, digitally signed if required. Automated and quality diagnostic laboratories, preventive and promotive healthcare. We have done already in 2020 8 public awareness and education series program, and we do regular seminars as well as journal club, which I gave it a name as National E-Journal Club, where there are institutes from the country participating. Customer friendly services and care. I invite you all to visit sometime, have a meeting there. Differently able compatible hospital, senior citizen friendly hospital, the first of its own type, having a very special clinic for the people above the age of 70 years who get services in one main hall: cardiology, neurology, nephrology, gastroenterology, and also inside ECG and physiotherapy. On the side is the sampling, on the other side is radiology. Dr. Vineet has seen the facility as well as registration on the ground floor. So our seniors have not to go even one step on the stairs to receive this facility. Continuing medical education and update. This is digitization. When I came, barcoding system, lab information system, I am proud that it is better than many private labs. I will not take name because then it will be like a conflict. This is all through PDF, URL, and not user ID and password because we tend to forget. Printed report, paperless EEG, 140 pages, but we give on DVD. Online appointment, biometric system that every hospital may have. CCTV surveillance, electronic display board for information of the public. R is to give with humane approach. and tender care. This is our motto, and I believe we may do less, but qualitative quantity will follow. And we treat all our patients as our guest on that given day. R is the only institution which issues 6 monthly newsletter, which is e-newsletter. It is PDF circulated to 50 government hospitals without spending single penny. What we have done so far, where are we now, and what are we planning for the future. This is like OPD barcoding system, paperless EEG. This I report on the EEG. One is given to the patient. He has the freedom to go anywhere and have another opinion. Then I also believe that we must have NABL. I am sure you must be aware, this is not a private hospital. In government, NABL is not easy. Many big institutes like AIMS and GB Pant are still not NABL. We are NABL in the very first year we got and maintaining till 2020. And then we have also entered entry level NABH and will be NABH full by this month. When I came, these were all semi-automatic. I said, no, it should be completely automated. That helped us a lot. And we can do 1,000 biochemistry and immunoassay tests per day. These are various services. I will not read. It may not appear that I'm boasting about it, but trying to give you the information about the institute to which I belong and from where I'm speaking. We got FICCI Healthcare Excellence Award competing against my alma mater, that is GB Pant Maulana Azad Medical College and Institute in Ahmedabad. This is, look at the senior citizen clinic, which is friendly hospital for senior citizen. It also extends special service to differently abled people, which may be from orthopedics also, as well as journalists and director general and those who are the beneficiary of CGHS, DGHS. We use the technology to the maximum. This is from, you can see my MS who says, sir, this board is ready, what else is required? Good, very minor changes required, I wrote. Then our nursing officer, then this is our senior resident who sends the report every day of the patient which have been seen by them. Now, I come to what is NCV and EMG test. Nerve conduction, velocity and EMG test from the form the core of electrodiagnostic study. That's called, by and large, you will say nerve conduction study kara lo, EMG kara lo. NCS includes both the things, nerve conduction velocity as well as EMG. Nerve conduction velocity is not actually the right word. Then NCV and EMG tests are complementary and therefore we mostly perform together and during the same setting. If EMG has to be done, first nerve conduction study must be done. Perform and interpreted correctly, these studies yield critical information about the underlying neuromuscular disorders. I will try today to cover NCV because if I cover EMG, it may become too much for you and too toxic for you. So if Vineet, Hitesh sir, Dr. Agarwal, Dr. Haq, they permit me, then I'll do in the second sitting sometime later. Now, the study must be individualized based on the neurological examination, very important. We must have the diagnosis, what I'm thinking. And is there any differential diagnosis? And modified in real time as the study progresses and further information is gained. Now, possible localization determined from the electrodiagnostic study. What can we achieve? It's not only that one nerve injury has happened, sciatic nerve injury or common peroneal nerve conduction study does that only. No. Neuropathic, like neuronopathy. What is neuronopathy? Before the root, ganglia. Then radicals, then plexopathy, then mononeuropathy, like one example I can give from orthopedic point of view, tardial nerve palsy, or Hansen. But you may find only one nerve, there may be the involvement on the other side as well, or multiple mononeuropathies, or which was earlier called multifocal motor neuropathy, that multiple nerves are involved, and then polyneuropathy. There may be silent involvement. That's why we do all 4 limb NCV and not one nerve, even if it is sent to us like that. Myopathic, proximal, distal, generalized, craniobulbar. Like you have facial palsy, Bell's palsy, you all are aware. So there is a facial electroneurography which we do. Same for facial muscles we do for postsynaptic, that is like myasthenia gravis, or presynaptic like Lambert-Eaton syndrome, maybe beyond your domain, but I need to mention. Then CNS diseases. We may have like multiple sclerosis, very well-known term to you. Now, key electrodiagnostic finding in a neuropathic localization. Fiber types involved: sensory, motor, mixed. When you are sending a patient, please ask. He may say, oh, I have got wrist drop. But ask him, do you have any positive sensory symptoms or negative sensory symptoms? Positive, I like paresthesia, and negative, I like hypoesthesia or numbness. Then you must also ask autonomic system, or feel the hand like this. How is it sweating compared one side, the other side? From the dorsum of your hand, which is most sensitive part, to tell whether autonomic system is involved or not. Is there any loss of hair? That will tell you there are small fibers also involved. Then pathological, axonal, demyelinating, which can be acquired or inherited. Temporal course, hyperacute, you must be aware of Landry-Guillain-Barré syndrome, many of you are aware, or Guillain-Barré syndrome. Acute, toxic, something toxic happens, like metronidazole or something, or alcoholic neuropathy, though usually chronic, subacute and chronic. Diabetic can be acute, subacute, chronic, all. Now, after the history is taken and a directed physical examination is performed, please do that before referring the patient to any laboratory. Every study begins with the nerve conduction studies, as I said. Even if EMG you ask, first nerve conduction study. The needle electromyography, you saw in the first girl, I don't know why didn't audio come, what was the reason, but when I played, it was coming very well. Needle electromyography examination is performed after the NCS is completed. Nerves usually can be easily stimulated and brought to action potential with a brief electrical pulse applied to overlying skin. Some people may be very sensitive. In them, what we do? First we do on ourselves. First we explain to them, a performer is there in our lab, we give to them to read, then we take their consent and start doing this. Then in the upper extremity, the median, ulnar and radial nerves are the most easily studied, motor and sensory both. In the lower extremity, peroneal, tibial and sural nerves are the most easily studied. You must be surprised why sir is not, or he is not mentioning sciatic nerve. Sciatic nerve is deep-seated. Usually we have to press the stimulus, the stimulator very hard. And at times, if not possible, we may have to do with the needle stimulation. Of course, the nerves selected for study depends on the patient's symptoms and signs and the differential diagnosis. Motor, sensory, or mixed nerve study can be performed by stimulating the nerve and placing the recording electrode over a distal muscle. I don't know why this is coming as these lines are coming. Somebody, I don't know, is moving his cursor. The findings from motor, sensory, and mixed nerve studies often complement one another and yield different types of information based on distinct patterns of abnormalities. Now, this is motor nerve conduction. You can see in this COVID era, we have to be extra careful. My doctor is putting on a PP kit, is also having gloves. And you can locate the muscle. This is abductor pollicis brevis. Now, this is black and this is red. Why so? Why red can't be here? I'll show next later. Now, in our lab, we don't say it is a lab, we say neurodiagnostic zone. And what is our team? Who has been well trained, well groomed. Dr. Vasundhara Agarwal, assistant professor. Dr. Yogesh Sharma with us for many years, senior resident. Dr. Anchal Agarwal, medical officer. Dr. Divya Gupta, medical officer. I must acknowledge them for contributing to this talk also. Mrs. Kritika Baneshi, EG technician, who is with us for 5 years, and she is one of the very good technician. And now Hoshyar Prasad, we have also brought from ECG lab, because soon we are going to have polysomnography, that is sleep study, and as well as epilepsy monitoring unit in our institute. Now, motor responses typically are in the range of several millivolts and are less affected by electrical noise and other technical factors. For motor conduction studies, the gain usually is set to 2 to 5 millivolt per division. There are vertical, there are horizontal. I'll show you later. Recording electrodes are placed over the muscle of interest. In general, the belly tendon montage is used. We know abductor pollicis brevis is here, and then there is a tendon. So I will show you which electrode is put where. The active recording electrode, also known as G1, is placed on the center of muscle belly because maximum number of motor units are there. And the reference electrode, also known as G2, is placed distally as far as possible over the tendon. The stimulator is placed, stimulator can be small or larger one, over the nerve that supplies the muscle with the cathode placed closest to the recording electrode. It is helpful to remember black to black. So black end of stimulator, black end of first electrode, indicating that the black electrode of stimulator, the cathode, should be facing the black recording electrode, the active recording electrode. For motor studies, the duration of electrical pulse usually is very low. It is set to 200. Should be read as microseconds, not milliseconds. Most normal nerve requires a current in the range of 20 to 50 milliamperes to achieve supramaximal stimulation. Some people jump with that. So in those situations, we do on ourselves and demonstrate to them. Now, recorded potential is known as compound muscle action potential. What does this mean? The action potential of muscle fibers in the muscles are compounded and represent the summation of all underlying individual muscle fiber action potentials. So you can see here, this one large is the muscle action potential. I'm sorry, this red mark is not going, please pardon me for that. The CMAP is biphasic. You saw in the previous one, this is the CMAP going from here, here, here to here. In electrical parley, this is called as negative potential, and this is called positive potential. Negative phase, positive phase. And you can see here amplitude mark, latency, duration. I'll come to that later. Vertical division, I said 2 millivolt, which will tell what is the amplitude. 2 millisecond horizontal on X line, X-axis is the duration of the potential. Now CMAP is biphasic potential with an initial negativity or upward deflection because this is away from the electrode and picks up from the baseline. For each stimulation site, the latency, one important, amplitude, duration, and area of CMAP is measured. A motor conduction velocity can be calculated after two sites, one distal and one proximal. The recorded potential, known as the compound muscle action potential, represents the summation of all underlying individual muscle fiber action potentials. That's what I'm highlighting second time for your better understanding. I don't know whether this will play or not. Let me see. Is it audible? Is it audible, Dr. Vineet?
Sir, it is audible.
Okay.
But the volume is slightly.
This is a Shaza from Northeast. We posted him in the lab and requested him to record how nerve conduction studies is done for teaching. This was done around 3 years back. I could have done myself, but we must promote and motivate our residents.
Sir, his volume is too low. If you can explain by, if you can narrate, that will be great.
Audio is not audible?
Yeah, it is very.
Or you can see the gesture what he is making. Just have a look at the gesture. This is motor action potential. This is the earthing, this is the recording electrode, this is the reference electrode. So black for black, this is median nerve stimulation. This is the proximal stimulation. We know median nerve crosses and comes, is medial to the biceps and then comes laterally. So this is important to monitor the or measure the velocity. So I think I'll stop this because then I'll go to the next slide and explain things. Now, what is latency? The latency is the time from the stimulus to the initial CMAP deflection. You can see here, the stimulus is this one and deflection is this one. So this horizontal bar is the latency. Latency represents three separate processes. The nerve conduction time from the stimulus site, which we are doing at the, say, near the carpal tunnel, we are stimulating. So it goes to the, through the nerve to the neuromuscular junction. Then the time delay across the neuromuscular junction, because that's a synapse. And thereafter the depolarization time across the muscle. Latency measurement usually is made in milliseconds and reflect only the fastest conducting motor fibers. You know, 1A, large fibers only, not the autonomic, not small fibers, not C and B fibers. So, or A delta and C fibers are not in this. There is a separate autonomic testing. Now, amplitude. Once it is stimulated, that muscle contracts. There is twitching of the, like this. It happens like this. Of the APB, CMAP amplitude is most commonly measured from the baseline to the negative peak, from here to here, and not from here to here, not peak to peak, but from here to the top. CMAP reflects the number of muscle fibers that depolarize. Although low CMAP amplitude most often results from loss of axons, as in a typical axonal neuropathy. Suppose conduction is going well, but the nerve fibers have degenerated, axonal, so it will be of low amplitude. Or if there is a muscle wasting because of, say, carpal tunnel syndrome, so then also amplitude may be low, one may think, or in a muscle disease, amplitude may be low. That necessarily may not be nerve disease. Other causes of low CMAP amplitude include conduction block from demyelination located between the stimulation site and recorded muscle, as well as some neuromuscular junction disorders and myopathies. Then comes area. Area is difficult to calculate by eye. So this calculation is readily performed by most modern computerized EMG machine. Differences in CMAP area between distal and proximal sites has great take on special significance in determination of conduction block from a demyelinating lesion. Duration is easy to calculate. Is primarily a measure of synchrony, the extent to which each of the individual muscle fibers fire at the same time. So duration will be start of this to the isoelectric line touching, that is the duration. Duration characteristically increases, usually not very small except in myopathic condition, in condition that result in slowing of some motor fibers but not others. That's in demyelinated figure. This is called temporal dispersion. Suppose it is supposed to be this, it becomes this. It is biphasic, it becomes multiphasic. So that's called temporal dispersion, and classically seen in acquired demyelinating neuropathies like Guillain-Barré syndrome. You will know that the most commonest. Now, conduction velocity. Motor conduction velocity is a measure of some, my orthopedic colleague may say only, oh, what's the conduction velocity? That's only one aspect. Is a measure of the speed of the fastest conducting motor axons in the nerve being studied, which is calculated dividing the distance traveled, as he was doing with the measuring tape, by the nerve conduction time, distal side and proximal side. to calculate a true motor conduction velocity without including NMJ, neuromuscular junction, transmission and muscle depolarization times, 2 stimulation sites must be used, one distal and one proximal. Now, how to remember that what has been done? So in that situation, what should be done? It's better to mark it. There are specific sites from the wrist crease to what level the stimulus should be used, as well as at the proximal part where it should be marked. So that, and now there are some late responses which I'm sure many of you may not be aware. Nerve conduction studies are most often used to access distal nerve segments. Few studies can be easily performed to assess the more proximal nerve segment, that is plexus and root. Suppose there is a brachial plexus injury. Now, our orthopedic colleagues ask us, tell us, is it axillary nerve injury or is it a brachial plexus injury? In those situations, this is very important, and also stimulation at Erb's point. In the arm, surface stimulation can be performed proximally in the axilla and at the Erb's point, although technical factors limit these studies, especially at Erb's point. It is in the supraclavicular region, but you have to have the expertise, training, and know how to do this. In the laboratory, 2 late responses I wish to inform my orthopedic colleague are F response. F stands for foot wave. It is not a reflex. It is on stimulation from the foot. It is recorded, and it goes via the motor, comes via the motor. And H reflex is a Hoffman reflex, which is because of stimulation of a sural nerve, goes proximally and comes by the motor nerve. So that's the difference. H reflex is the electronic or electrical component of the ankle reflex. Sometimes ankle reflex is not coming, you can do H reflex still, that reflexes are still preserved. Although both are usually thought of as assessing only the proximal nerve segment, in reality they travel the entire nerve segment from distal to proximal and back. One from motor to motor, the other from sensory, afferent to efferent. Thus, they are most useful when routine nerve conduction studies, which assess distal segments, are normal and late responses are abnormal. I think I'll take another 5 minutes and then stop on nerve conduction study, because the EMG will take much longer time that I can do sometime later. You can see the F wave here. These are the F waves. You will say, oh, this looks so small. What is this? This is the F wave, and then they are summated. And we take the average minimum F wave and maximum F wave. You can see here F wave, these are F wave, and then we combine them, summate them, and this is the H reflex. In F wave, just to remember for residents, in the upper limb, it is less than 30 milliseconds. And in the lower limb, it is 60 milliseconds. Depends on the height also. If somebody is more than 6 feet, even 62 may be acceptable. But by and large, a corollary is 30 and 60. Now, motor nerve conduction setup. Median nerve motor study, recording the abductor pollicis muscle, stimulating the median nerve at the wrist using the belly tendon method being done in our lab. This is one example. And this is the one which I have shown you earlier also. And this is the sensory nerve conduction, which I pass on quickly. It is a little different, sensory nerve conduction. But here you will see amplitude is from isoelectric line to the peak. This is the duration. Latency is not of great significance, but we do measure the latency also. Here, it is 10 microvolt height. There it was 2 millivolt. Sensory potentials are lower amplitude. And then snap represents the summation of all the underlying sensory fiber. If you send to us, say, do the radial nerve, we'll not do only motor, we'll also do the sensory. Onset latency represents nerve conduction time from the stimulus to the, it was just like motor. Amplitude most commonly is measured from baseline to the negative peak, but some people measure peak to peak. Now, duration is like motor nerve. On one stimulation site is required to calculate a sensory conduction velocity. Here you don't require proximal and distal. This is like sensory stimulation. You see here there are ring electrodes. There are cup electrodes. These are ring electrodes, and this is a antidromic stimulus, not orthodromic. Antidromic stimulus and then it goes back and comes. And this is the sensory nerve action potential. Very useful in carpal tunnel, motor involvement, sensory involvement, and then EMG may be required when you send to us. I don't know, this also may not play. Okay. Now, important technical factors influencing NCV and EMG, I'm coming towards the end. Physiological factor, temperature, age, height, proximal versus distal segments, and anomalous innervations should be kept in mind. Now, it should not be a very cold lab. In winters, you have to heat it up to keep a temperature which is comfortable, say around 29-30 degree. In summers, 23 degree. Non-physiological factors, electrode impedance, cathode position. If you reverse, then the recording will not be good. Stimulus must be supramaximal, on which the motor fiber record. Co-stimulation of adjacent nerve. One should not stimulate two nerves. If you are doing near the medial epicondyle, you may stimulate both median nerve, which you take it higher up, and ulnar nerve. Antidromic versus orthodromic recording I have shown. Distance between recording electrode and nerve, these are fixed on an average in person, that how many centimeters from there. Now, this is our recordings from our institute. You can see usually in the upper limb, I thought I'll tell this way, velocity is between 50 to 70 meters per second. This is in meters per second. Latency in the upper limb is less than 4.5, and in the lower limb, less than 7. You can see here the conduction velocity is between 40 to 60. So this is a normal conduction velocity, except in the tibial nerve. Tibial nerve, one should be careful because it needs to be stimulated well. If you find isolated, it may be technical error and do it again. This is also like the nerve conduction studies in one, and as well as the sensory nerve conduction studies. You can judge here motor nerve conduction right median. Now the amplitude is 4.5 millivolt. You will ask, what is the normal amplitude? You have not told us till now. 3 to 15. Usually 5 to 15 we say, but 3 to 15 is also okay. And then on this side, you see ulnar is a very low amplitude. It means there is an ulnar nerve affected. In the right median, you will see F wave is 29.1. I said 30. So this is normal. Here it is 32.1. This is 32.1. So what's the problem? This was a tardy ulnar nerve palsy. Then again comes the sensory. You can see here motor nerve, very low amplitude, and here also low amplitude, less than 3 or 5 millivolts. So this signifies that there is a low amplitude, but latency is normal. So again, this is a axonal neuropathy. Now EMG, I'll just not read any slide, I'll just run, but if required, and depends on the Delhi Orthopaedic Association, Sharad Agarwal sir, I have never met him, heard him so much about him, Dr. Hitesh, Dr. Vineet, Dr. Haq. If required, I'll be happy to do EMG if it's of relevance to the residents, and it is not too much for them. So these are something about the EMG.
Sir,
yeah.
I think you can take your time for EMG. I think resident will be happy to hear it.
Are you sure?
Yes, sir. Sure.
This may not be too much. This may not become toxic lecture.
Not at all. Not at all. Sir.
Okay, because then you will cross 4 o'clock. That's why I thought we'll take more questions.
It's okay, sir. We will take it.
Okay. After the nerve conductions, as we said, suppose you send to us wrist drop. You send to us Bell's palsy. Bell's palsy may not be in your domain. You send to us brachial plexus injury. First, we'll do nerve conduction study and then EMG. Each needle EMG study must be individualized. You didn't see that Mrs. Rita Arora, once she said, ouch! So it is painful process. We have to explain to the patient that it will cause pain, but I am there to make you comfortable. Must be individualized based on the clinical findings and differential diagnosis. Almost every muscle in the body can be studied with EMG. However, to do so is like you may think what all muscles can be done. You can do in the cervical region, you can do in the crural region, you can do in the brachial region, but you can also do paraspinal muscles. Very important to know if the roots are involved. neither practical nor desirable for every patient. As I said, not that all muscle, but this is the clinical judgment. So balance must be reached between the need to study a sufficient number of muscles to reach or exclude a diagnosis and the limits of the patient's ability to tolerate the examination. I'll give you motor neuron disease, you must have heard. In that, we need to do 3 segments. Now, what are those 3 segments? One is cervical, one is brachial, the other is crural, or the spinal, paraspinal. So, if suppose patient has got fasciculation in the upper limb, we must also study the lower limb, even if we are having clinical suspicion of ALS and or motor neuron disease or Lou Gehrig disease. And we must ask the patient as well that do you have fasciculation somewhere else? And we can also differentiate. Many doctors say, oh, friend, I have got fasciculations. Hope I am not going to get motor neuron disease. I got an associate professor from Jodhpur. Sir, I have got fasciculation all over the body. Hope I don't have motor neuron disease. That was all because of anxiety. Other common condition is hyperthyroidism, which is physiological. Then choice based on the following fact. Differential diagnosis determined by the clinical finding and nerve conduction data. Again and again, sound clinical judgment and examination and nerve conduction data. The case with which muscle can be located and activated, although both the tibialis anterior and medial gastrocnemius are distal leg muscles, the tibial anterior much easier to activate than medial gastrocnemius. The degree of pain associated with sampling the particular muscle must be kept in mind and taken into consideration. If there is an indication that patient might not tolerate or complete the entire examination, the most important muscle should be sampled, not that every muscle. Not technician को आप एक direction दे दें, please do the EMG. No. For instance, if the patient has proximal muscle weakness and the differential diagnosis rests primarily between a myopathy and proximal neuropathy, it's called brachial plexus injury. You want C4, C5 assessment also. C5 will be distal in the deltoid or biceps or brachioradialis to some extent. In that situation, you can go to paracervical or erector spinae cervical component to see fasciculations. Plexopathy, radiculopathy, motor neuron, it makes sense to sample a weak proximal muscle first, not strong. In addition to EMG machine, an EMG needle is usually a disposable needle. Needle cable, ground electrode and gloves are necessary to perform the needle. No EMG should be performed without gloves. It may prick me. The ground electrode is applied to the limb being studied in order to suppress noise and for electrical safety. Usually it is a concentric or a monopolar EMG needle which is used. When an electrical potential is measured during the study, voltage is measured as the difference between the active and the reference recording electrode. You can see here the needle being put, patient needs to be asked to relax. This will take around 10 minutes, no problem.
You can go ahead. We have time.
Okay. Thank you. But I'm not asking for any honorarium second time. Don't worry about that.
Okay. Thank you, sir.
Okay. Patient preparation and typical needle electromyography examination. It may appear, what is this? Janapuri people are not doing EMG. All this is required. Or GB Pant is not doing, or AIMS, where SMART is there, that they are not performed. Why? Explain the electromyography procedure to the patient to allay any patient fears. Very important. First, select first muscle for study. Locate muscle by using anatomic landmark. Show patient how to activate muscle, because this is not only, we have to do at rest, then activate. Ask patient to relax muscle. Insert needle into the relaxed muscle, not contracting muscle. Ask patient to contract muscle slightly to ensure proper placement. Ask patient to relax muscle completely. Sometimes even for us it may be difficult, but you have to show, like if patient is doing like this, then he's contracting. You have to say, keep your hand like this, relax your APB, only then I can do. Assess insertional activity. These words may be new for you. And spontaneous activity. Sweep speed is usually full oscilloscope is 10 millisecond per division, and sensitivity is 50 microvolt per division. Perform 5 to 10 brief insertions in all 4 quadrants. Assess MUAP. Then after the insertion, ask the patient to contract muscle slightly and gently, needle until MUAP becomes sharp. I'll tell you what is motor unit action potential. There we learnt about compound muscle action potential. There are number of muscles. Here single unit we are picking up, not all units. Assess several locations for MUAP duration. It should be ideally in the center of the muscle. That's the best place to pick up MUAP. Proceed to next muscle. Now, what is insertional activity? When we insert, it touches the end plate and there is insertional activity. This will come but should not persist. If it is persisting, that the membrane is hyperexcitable, which can occur condition like very fast degenerating or regenerating muscle or polymyositis. MUAP. After assessment, what we read about CMAP, insertional and spontaneous activity, these two are different. You put the needle, there will be insertional activity. Then you see the muscle is relaxed, but something is still coming up. So that will be spontaneous activity if the muscle is completely relaxed. And then we use MUAP. In a process similar to the analysis of spontaneous activity, MUAP must be assessed for morphology. Again, here come like CMAP, duration, amplitude, how many phases. Normally these are 2 or 3 phases. If it is polyphasic, it indicates active denervation. You will say, sir, I have operated on this, somehow the radial nerve got injured. Tell me what's the long-term prognosis. And these may have to be done serially, not one time, to prognosticate. Suppose initially there are no MUAP. You do second after 3 weeks or 1 month, MUAP start coming. I'll say, Dr. Hitesh, Dr. Vineet, Dr. Haq, this patient is likely to recover. He will say, how come? Because now I can see here some activity that some muscle fibers are recruiting and there is a activity. In a process similar to the analysis of spontaneous activity, MUAP must be assessed, what I have already mentioned. The pattern of MUAP allows a determination of whether disorder is primary neuropathic or myopathic. You will say, how, sir, you can find out that? We'll tell you. And often helps determine the time course, acute versus chronic, and severity of the lesion. Often is quite demanding. You will say, patient भेजा अभी तक वापस नहीं आया. It may take 2 to 3 hours on one patient. And these are done only 1 or 2 procedures a day, because simultaneous lab is also doing EEG, is also doing evoke potential, and their limited manpower. The task of evaluating MUAP is made all the more difficult by the wide variation in what is considered a normal MUAP, depending on the muscle being studied and the age of the patient. Now you will see here, this is a motor unit action potential, and you can see some serrations, but it is a biphasic wave. Interference pattern. Then we ask the patient to contract the muscle fully, and the interference pattern. You can see here, one is A. You can see here it is complete. It's of a normal patient, normal person, not patient. This you can see all potentials are separate. So this is decrease interference pattern, or we call decrease recruitment, that all muscle fibers are not recruiting at the same time. And then this is a low amplitude. You can see here, this is low amplitude. So this happens in muscle disease. These two are normal, nerve disease, muscle disease, and this is some spontaneous activity. Now it can be normal, neuropathic, myopathic, central, either of that can happen. And this is the way. This is in COVID era. Dr. Divya Gupta is performing an EMG. She is our medical officer in charge of nerve conduction study lab. And you can see here, double mask, head cap, PPE, gloves. Very important. And patient, obviously we will clean the area. And by and large these days we are doing first RAD test and only then doing these studies, which I think every hospital is doing these days. Now, spontaneous activity is very important to know because it may be interpreted as a normal activity. Now, analysis of spontaneous activity morphology. I'll not go into all this detail. because this will become too boring. This is not a class for neurologists, but you can see morphology, stability, firing characteristics. These are the one which are very important to know. Fibrillation potentials. This one which I have showed you earlier was the fibrillation potential. I'll show some pictures because all this text may not be good for me to read, but where you pick up fibrillation potential, suppose you pick up in the paraspinal muscle, means roots are also involved. Now, these are typically very low duration, 10 to 100 microvolt. You can see on the baseline here, these are the fibrillation, very sharp, just like tick, tick, it comes like this. And this is like rain on the roof, which when we get rain, we say, oh, drip, tuck, 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 like that, it comes. And then comes positive sharp waves. These are also sign of degeneration. And in this, there is it is like a pop, 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 it comes like that. And then there is a fibrillation potential. They have a regular firing pattern. So this is a positive sharp wave. You will be surprised it's going down. Why we are saying positive? In electrical parley, that is what we say, that it is surface positive, but it's going negative downwards because of the recording electrode and the reference electrode. Then complex repetitive discharge will be beyond, I think, but this is, you can see here, complex repetitive. This can happen when the nerve injured is regenerating. So it's a good sign. If we see CRD, we can say this is what happening. Fasciculation potential, again, a sign of degeneration. And now what happens? Somebody may say, is it a physiological fasciculation or pathological? So easy, which my teacher, Bhagwan Tishani in University of Illinois, Chicago, where I went, was teaching, is 1 in 3 seconds is pathological fasciculation. 3 per second is physiological. If they are occurring too frequently, they are physiological. If they are occurring 1 to 2 hertz like this, then they are pathological. These are the fasciculation. You can see compared to that spike or fibrillation, these are much wider. Look at this, much wider. And it has 1 phase, 2 phase, and 3 phase. Here it has 1, 2, 3, 4 phases. So multiphasic, triphasic is all right. If it is 4 phases, 5 phases, it's a fasciculation. Now take home message from my talk. NCV and EMG, NCS is an important tool in the diagnostic armamentarium in neurology and related specialty like neurosurgery, orthopedics, rheumatology, etc. Proper procedure explanation. Don't take the patient guaranteed. चलिए आप लेट जाओ मैं आपका टेस्ट करूँ. No, those times have gone. One has to be, this is a professional requirement. Consent and cooperation of the patient is very important. You will see I am putting PEP, proper procedure, CC, consent and cooperation. Good requisition form is the pre-requirement, whether it is coming from neurology or allied specialty. Neurology is no exception. Resident has to fill a proper form, which we have. Then we have a consent form for nerve conduction study and EMG. Nerve conduction study is a very specialized investigation and of immense diagnostic value with a good clinical diagnosis, but sometimes serious studies may have to be done. It is usually understood, but must be very clear in mind that what is our requisition for this study. With this, I will sincerely thank everyone for the patient listening. With this, I stop sharing, Vinitji, and thank you for giving me this opportunity. Thank you so much.
Thank you very much, sir. Thanks a lot for your so much elaborative and extensive description of the NCV and EMG. I think most of the things must be.
Now I can have a glass of water now.
Yeah, sure, sir. You can have before we can take on the questions.
Yeah, please.
Of the various panelists.
Yeah, thank you.
I request all the panelists or the delegates who can put up their question either in chat or they can ask directly from the sir also. We have been happy to have him today in the afternoon. Sir, before others are starting, first of all, I just want to know, in case of orthopedic scenario where we are getting NCV and EMGs routinely for the nerve injuries, This
Yes,
is the
sir.
most common scenario, either post-operative, post-traumatic, and all that. So
Mhm.
as you said, we need serial NCV and EMG to diagnose the prognosis, to diagnose it and to see the prognosis. So what is the earliest time when you should go get the NCV or EMG done, these NCS studies, and how frequently we should do it just to confirm it whether the patient is improving or the chances of improvement or not?
Suppose nature is not uniform. Sometimes you get a patient who has got injury in the supracondylar area. There may be muscle injury, there may be tendon injury, there may be nerve injury, right? So in those situations, suppose we have to find out whether nerve is involved or not, an assessment may be difficult. At that time, nerve study should be done immediately. And you can also say whether it is swollen, tender, any hematoma is there or not. So time of 2 to 3 weeks for resolution of that should be given, and then EMG should be done. In acute nerve injury, EMG may not be immediately forthcoming, but nerve studies, nerve conduction study may be very valuable. And if you want to do serial, there's no definite time, but 3 to 4 weeks for the nerve study, and the EMG must be done in around 6 weeks time, because it takes time. It takes a fastest time to degenerate, but for regeneration, you know the speed, it comes up very slowly. 0.1 millimeter per week or so. So it will be very slow regeneration.
So that means first time when we are having a patient with the injury, we should either get it, if we are not sure about the nerve injury, then we should get it immediately to find out whether nerve is involved. And if we are sure,
But 1 minute. But in requisition, you must ask your residents to give full details and also judge whether muscle is injured or not, whether there is any hematoma or not. At least before sending to us, an ultrasound of that area can be done. Ultrasound is very helpful these days, even to pick up nerve injury. I'm looking after neurosonology. I'm the president of Society of Neurosonology in India. So we have two aspects: vascular neurosonology of the neck vessels and the brain, called transcranial Doppler, and also neuromuscular. We have picked up so many Hansen disease, thickened nerve by ultrasound alone. And even in CIDP, there is a role of ultrasound. So you must get ultrasound of that area, because that's easy, non-invasive. Yeah. And not painful.
right. Sir, is there a role of MRI also? Because many times they say we have MRI correlations also required.
MRI is of immense value, and you must tell the radiologist to carefully trace the tracks of the nerve, as well as, if required, give a contrast, if required.
So that will help us leading to diagnosis, or is
Yes.
it going to only determine the site of injury?
Site of injury, NC will give you extent of injury as well as the functional status, while ultrasound and MRI will give you static status.
Okay, that's very great. So, uh,
आपने म्यूट कर दिया भाई साहब अपने आप को. You have to mute me, not to yourself. I have spoken too much.
no, sir, we don't need to mute you. You are a special guest.
जी.
Sir, one of the questions a resident asked us, what is the role of NCS studies in ankylosing spondylitis patient?
Hardly any, because it is a sacroiliitis, we know, HLA-B27 labeled. When this patient came to us, which I showed you, somehow I don't know why didn't video play, he was ankylosing spondylitis and CIDP. Somebody thought all is because of ankylosing spondylitis. But when we asked him, then he said, I have got paresthesias in the limb, there's a dorsiflexor weakness. So it's beyond. And there was neuropathy, CIDP. I think he's coming for 1 year. He came on a wheelchair, and now he is walking fast as I can walk. So he has recovered so much. Timely diagnosis, timely intervention.
One question, sir. Can
Yes,
I
sir.
ask?
Yes, sir, please.
Ji, sir. बहुत मुश्किल ना पूछना डॉक्टर हितेश जी,
Okay.
मुश्किल ना पूछ हाँ जी
Dr. Pradeep,
How early can you differentiate between exontomesis and neurotomesis by nerve
Yeah.
conduction velocity
Yeah,
before the
yeah.
clinical signs appear?
That's right. If there is no local swelling, no local hematoma, what we do, suppose you ask me to judge here the ulnar nerve. So what I will do, distally I will do ulnar nerve here near flexor carpi ulnaris. Then I'll do behind the medial epicondyle. Then I'll go up to our point and see where it is not coming. Then I can say, oh, this is the area it is not coming. If there is no other inhibitory factor like hematoma, swelling, or those things. So this nerve injury can be judged immediately. Now, exontomesis, because axon, it means the myelin is still intact. It will conduct, but the amplitude will be low. Amplitude will be low. If there is a neurotomesis, then because that's a Wallerian degeneration happens later. If the neurotomesis means the complete, there is spherence of the nerve, there's no conduction happening. So it will not show any amplitude between the two segments.
One more question, sir. In our postgraduate days, we were talked about the strength duration curve. Is it of relevance today or not? Strength
Pardon?
duration curve. Strength duration curve.
No, I have not got your words.
the stress
Strength
duration
duration curve, sir. Strength duration curve.
Yeah, that's still, you are talking of Samson Wright or Guyton, still it holds valid. It holds valid. Dr. Pradeep, sir.
Yes, Dr. Pradeep, can you please go ahead?
Yeah. Good evening, sir. It's a very wonderful talk.
Thank you, sir.
I've got one clinical question, sir. In orthopedic practice, carpal tunnel syndrome is very common by us, and the report comes in the form of mild, moderate, and severe. When we should tell the patient in a very affirmative way, now the time to go for surgery, like in moderate or severe, or how to judge the report.
That's right. That's right. That's what I'm saying. When you think that it is carpal tunnel, you should be very sure it is only carpal tunnel, number one. You must ask the patient that patient doesn't have hypothyroidism, patient doesn't have local injury, patient doesn't have diabetes, diabetic mellitus. So these are the common causes. Hypothyroidism, diabetes, injury. Now, second, while sending, you must see whether there is a wasting of the APB muscle or not, whether motor and sensory both are there or not. The patient of carpal tunnel are most miserable in the night. They wake up with the pain in the night, right? Especially when the wrist is flexed. So you can do Tinel sign, you can do those things. And if there is a muscle wasting, it means it's quite advanced. And still some power is preserved, time to intervene. If not, when patient come to me, APB is well preserved, there is mild sensory symptom which are positive, not negative. Muscle power is good. I'll give them a splint and give them some painkillers, which are nerve specific.
Right, sir.
I still prefer to give carbamazepine. I know a lot of people give gabapentin to start with and also give pregabalin. So if required, then we add that because gabapentin, and this is useful in neuropathic pain, and a lot of patients get for radiculopathy pain also. That should be avoided. So carbamazepine for some time, a splint, and to be careful about usage of that hand in flex position.
Right. Thank you, sir.
So just adding to the Dr. Hitesh's question, how early we are able to diagnose whether it's a neuropraxia, axontomesis, or neurontomesis, because in our orthopedic patient, there is the most common injury which we are dealing with, and whenever this comes, and we are always afraid of whether it's a praxia, axontomesis, or neurontomesis.
See, neuropraxia is like a shock. We can say like septic shock. We start antibiotic, we start fluids, we start dexamethasone if required, not in all cases. Patient starts recovering fast. So if it is neuropraxia, in the beginning it may be difficult to find out because say the whole nerve is in shock, but then we come to know it has recovered very fast. So if you have done one study now, you can do another within 10 days or 2 weeks. In this situation, we cannot wait. Then another in a week or so. that will tell us clearly, was it retrospectively, was it neuropraxia or was it neurotomesis?
Okay. And of course, when you're talking about axontomesis and neurontomesis, it is, do we have some findings which are suggesting us, like when we are interpreting the NCS studies?
Yeah, neurotomesis, like the latency will be very prolonged or may not be recordable at all, number one. Maybe suppose there is an injury here, distally we do, it will be recordable, but proximal will not be recordable. But with the passage of time with Valerian degeneration, even distal will go away. But if there is recovery happening, even from proximal we stimulate, some flicker may come, may become better amplitude and more amplitude like that.
So if we are getting these flickers, that means that is a right way. That means the muscle is recovering.
Good sign that the nerves are getting connected in a natural way.
All right. So yes, Dr. Samit, please go ahead.
Sir, we often operate and we often put implants in the bones. Sometimes there's a confusion whether the nerve is compressed between the fracture fragments, or is it really injured by any of the implant or by our knife or even with a drill. So is there a way we could know whether it's a compression injury to the nerve which might need re-exploration, or it's a clean-cut injury, or maybe neurotomesis or anything short of it that might need kind of a graft or a nerve repair? Any way, sir, to know that?
Sir. If the patient how was it before going for implant, that will be your judgment. And after the implant, how the patient is, that's your judgment. But definitely, if before that you want to know that nerve is affected, is it because of the bony spicule or edema or that? In those situations, as I said, ultrasound, CT or MRI will be very useful. In addition to NCV. NCV, nerve conduction study, is very useful, but as I mentioned again, it's complementary. Complementary to the clinical judgment which God has given us, this mind and brain, and good clinical examination, and then this one. Yeah. Large number of my faculty member residents from India and abroad are also attending.
Yeah, sir. Thank you very much, sir. We are really great to invite them. Yeah, Dr. Manocha, please.
Sir, it was a very good lecture. I learned a lot. My one question is that my spine surgeon here, in all cases of disc cases, he orders an EMG NCV, and I don't understand why, because when we already have seen on MRI a disc compressing a particular nerve root and the sign symptoms present in that particular dermatome and myotome, then still they are ordering an EMG NCV. Can I really get an insight why it should be so?
Sir, I can speak only about myself. Once they are sending what I said, a good prerequisition. When I'm sending, I must be clear why I'm getting it done, what will be the advantage, and what will I get out of this. So as far as if there is, suppose L5S1 disc, there is S1 radiculopathy. So I won't say anything beyond, they will get angry with me. So by and large, in my practice disc prolapse, good clinical judgment. I tell you one example. One of my colleagues, I'll not say which one. We should not treat MRI or black films, I say always. We have to treat the patient. One case was presented in the joint meeting in the GBPAN, and that patient was presented and it was said, sir, clear presented, and then ankle reflex absent. Sir, this is the MRI L5S1. Tomorrow we are going to operate. Maine kaha, what? The patient or the disc? There was only ankle reflex absent. Patient had no weakness. I said, sorry, if you ask my opinion, this patient should not be operated, and that patient was not operated. So I think I have given clear answer.
So
या और तो फिर फोन पे बताऊंगा डॉक्टर मनोज साहब.
Right.
Sir, similarly, in adding to Dr. Manocha's question, I think there was a question on the chat also by one of the students, and he also wanted to know the same thing, whether after getting the MRI in the patient with complete paraplegia or spine surgery, do we still need to do the NCS, or it is?
Yeah. This situation is very different. The other day, 1 week back, one gentleman who is elderly was brought to me, and he had a big disc, and he has a vertebral collapse, and he had anemia. He was multiple myeloma, but he's walking around. He has been fixed for surgery next day. I said, surgery, what? He may need stabilization. He may need stabilization if it is a mobile spine. But otherwise, what are we going to operate? He doesn't have any deficit. He doesn't have any sensory loss. He doesn't have any bladder dysfunction. Is it preventive or therapeutic? So that's what I gave them clear opinion. In my opinion, he should give rest to the spine by lumbosacral corset. He should not move, should remain immobile, whether by some splint or whatever devices, and then see over the period, and anything subtle happens, any means weakness, bladder, we should be immediately operated. So the boy is right. In that situation, if there is a transverse myelitis, in that NCV EMG is not helpful. Now what is helpful? There is an entity called somatosensory evoked potentials. You can do and see, and motor conduction. From brain you do and record from the lower limb. It will tell you whether motor fibers are conducting or not, corticospinal. And if you do from lower limb to the brain record, it will tell you sensory fibers, afferent fibers are working or not. So that can be helpful in prognostication. But those are, again, you need a lot of expertise. In that, electrode are put at C5, C7, and then in the parasagittal area in the sensory cortex and motor cortex.
So you mean that in the case of spinal cord injury, these somatosensory potentials are very useful, and that can let us know whether
can be useful. No, I didn't say can be useful depending on case to case. Every diagnosis, every investigation must be customized to the need of that patient, and not a blanket like इसमें ये करा लो, ये करा लो, ये करा, ऐसे नहीं, बिल्कुल.
Right. Actually, so what is happening? Dr. Manocha has asked the same thing. When we are operating on spinal injury patient, there is some compression over there because of the prolapse of the disc as well as the retropulsion of the bony fragment. What happens? We are not in position, I mean, after stabilization of spine and decompressing it, we are not in position to tell him the prognosis, whether it will recover or not. So is there any way which we can let us know that now your spine will recover?
First is, sir, you may be spending 4 hours on surgery or 5 hours, but at least 1 hour must be spent on good history and clinical examination. Many times we may not ask, we will say, do you have any bladder dysfunction? But ask him in more detail. Get an examination done from your colleagues, maybe from a neurologist, who can also, because they will do examination in longer time. And somehow neurologists have more patience. So you can get it done, good examination, ask them to give the level and the chances of recovery, also prognosis. And then if required, this motor conduction and sensory conduction may be helpful. I'm saying central conduction, not the peripheral.
Okay, central.
And suppose there's a damage, we do paraspinal EMG, we find fibrillation, we say, okay, now roots are getting disconnected or have got disconnected.
Right. And so what about after the nerve repair? Is there a role of NCS?
See, what do you want to see after nerve repair? Clinical recovery and electrophysiological recovery may be earlier than the clinical recovery. Sometimes you may think whole nerve is cut off, but patient power is pretty good. You are exploring, you see nerve is this thin, millimeter, but power is good. Don't touch it. This is natural. Nature is great, sir.
Right, sir.
We are only human beings, not gods.
Right, sir. Hitesh, sir, please. Dr. Hitesh, sir.
Any question or what?
Yeah.
So postgraduates are often asked what is galvanic and Faraday current. Can you explain that to them?
These days, these are not taken into consideration much. This was told in the first and second year of what we do here. What is either DC current, that's what we used, or alternating current, that's what is used. in this. So galvanic and Faradic used to be in physiology level, but in our terminology, there is no more used. Definitely you do that when you are doing intracellular recording, when you do put an electrode in the cell and record the potential, like intracellular first will be negative, then positive, depolarization, then repolarization.
Maheshwari sir, you have any comment? Dr. Maheshwari, are you there? I think we are not, he is not connected right now. Anyway, sir, I think if there's no more questions, shall I ask Dr. Hitesh Lal to have a vote of thanks?
Okay, I, on behalf of the Delhi Orthopaedics Association and as an alumni of Maulana Azad Medical College and a resident of Janakpuri, sir,
Oh my
thank
God.
you for a wonderful talk. And this is bound to come as a short case in postgraduate examination as well as a short note. So thank you for a very wonderful talk and a very educating one too. Thank you from Delhi Orthopaedics.
Thank you, sir. Thank you.
Humble, thank you so much. Grateful. Thank you.
Thanks, sir. Thanks a lot.
Thank you. Bye-bye. Bye.
Thank you, Samarth, and all the delegates and faculties for attending and sparing their time for us. Thank you very much.
Bye-bye. Take care.
Thanks, sir.
Can I leave the meeting now?
Yes, sir. We shall be disturbing you again also in case.
Okay, Viniji. Thank you so much. Thank you, Samarth, for wonderful coordination. And I'm sorry somehow video didn't work. I tried on my desktop, laptop, it was working perfect. I didn't use the earpod for this reason, because that